to This Explainer. Today, we're going to treat clinical audiology a little differently. We're going to approach it like a medical detective story. Our mission? Hunting down the invisible causes of hearing impairment. Because honestly, when a patient sits down and says, "I can't hear well," that is just the tip of the iceberg. The real challenge, the true mystery, is figuring out exactly where and why the system is failing when it's hidden deep inside the human skull.
So here's our investigation manual for today. We're going to cover 1. The 4 types of loss. 2. Basic bedside interrogations. 3. The electronic polygraph. 4. Forensic brain tests. And 5. Specialized assessments.
All right, let's jump straight into section 1, the 4 types of loss, identifying the suspects.
Okay, the fundamental distinction you really need to grasp right out of the gate is whether the issue is mechanical or neurological. On the mechanical side, we have conductive hearing loss. Think of this like a blocked pipe. Something is physically interfering with sound getting from the outside world into the middle ear. I mean, we're talking about impacted wax, a perforated eardrum, fluid, or even the physical stiffening of those tiny bones in the ear. On the flip side, the neurological side, we have sensorineural hearing loss. This happens way deeper inside. We're looking at microscopic damage to the actual sensory hair cells in the cochlea, or a problem with the 8th cranial nerve and its pathways to the brain. So, as detectives, our ultimate goal is to figure out exactly which of these 4 core categories our patient falls into. Is it strictly conductive? Is it sensorineural? Or maybe it's mixed hearing loss, which literally has elements of both. We see that a lot in conditions like otosclerosis. But wait, there is a 4th suspect here, and it's a fascinating one: non-organic loss. This means there's no physical lesion at all. The patient could be malingering, which is just a fancy medical term for faking it, usually for a financial payout, or the loss could be entirely psychogenic, and we have to be sharp enough to catch that too.
Moving on to section 2, basic bedside interrogations, simple clinical tests.
Now, you might think we start with million-dollar machines, but our investigation actually starts as simply as measuring distance. 6 meters to be exact. In a basic speech test, a healthy ear should be able to clearly pick up a conversational voice and even a whispered voice from exactly 6 meters away. It's incredibly low tech, but honestly, it's a brilliantly practical initial screening method. Next up, we bring out the tuning forks. We use a 512 Hz tuning fork to perform what's called the Rinne test. This is where we compare how well the patient hears sound traveling normally through the air versus sound vibrating straight through the bones of their skull. Now pay close attention here, because the medical naming convention is totally counterintuitive. A positive result on this test is actually normal, or it points to a sensorineural loss, meaning air conduction is still better than bone conduction. But a negative result? That means bone conduction is suddenly outperforming air conduction, which completely gives away a conductive block in the outer or middle ear. Then we have the Weber test, which is just absolutely fascinating. We take that vibrating tuning fork and place it dead center right on the patient's forehead. The sound will physically pull or lateralize to one side. If the patient has a conductive blockage, the sound bizarrely pulls toward the poorer ear. Why? Because that physical blockage is actually masking out background room noise, making the bone-conducted tuning fork sound surprisingly loud on the bad side. But if they have a sensorineural loss, the sound will lateralize over to the better, healthier ear. This matrix right here brilliantly illustrates how we cross-examine our suspects. We never rely on just a single test. By combining Rinne and Weber with other assessments, like the absolute bone conduction test, Schwabach's, and Bing's test, we weave together a really tight web of data. Take Schwabach's test, for example. We literally compare the patient's bone conduction directly against the examiner's own hearing. By cross-referencing all these clues, an audiologist can pinpoint the exact location of the lesion before we even touch a single electronic dial.
Which brings us to section 3, the electronic polygraph audiometric testing.
When the bedside clues aren't quite enough, we escalate to pure tone audiometry. We put the patient in a soundproof booth and map their exact hearing thresholds across a very specific quantified range, from 125 all the way up to 8,000 Hz. We are systematically graphing, pitch by pitch, exactly what they can hear and what has dropped completely off the map.
By charting both their air conduction and bone conduction on this audiogram, we start looking for something highly specific: the air-bone gap. This is literally the measurable difference between those 2 thresholds. Once we find that gap on the chart, we can precisely quantify just how severe the mechanical interference is in the middle or outer ear.
But here's the thing. Hearing pure, isolated beeps is definitely not the same as actually understanding human language. So speech audiometry moves beyond the beeps to test real-world word understanding. We calculate their speech reception threshold and their discrimination score. We're keeping our eyes peeled for disproportionately poor discrimination or this incredibly strange rollover phenomenon. This is where making the sound louder actually makes the patient's word understanding worse. If we see that, it is a massive red flag that the problem lies deeper in the nerve itself, not just the inner ear.
Up to this point, every test we've done requires the patient to actually participate, to raise a hand, press a button, or repeat a word. But here is the major plot twist in our story. What if our subject is an infant who can't cooperate? Or what if they're a malingerer, intentionally feigning deafness for a huge insurance payout? What do we do then?
That leads us into Section 4, Forensic Brain Tests, Objective and Electrophysiological Tests. To bypass the patient's conscious control, we automate the investigation using impedance audiometry. Step 1 is tympanometry. We bounce sound waves directly off the eardrum to measure the compliance or flexibility of the entire middle ear system. Step 2 is the acoustic reflex, and this is where it gets really cool. We shoot a loud sound into the ear, and the machine detects the tiny, involuntary flinch of the stapedial muscle. That is the smallest muscle in the human body, and guess what? You literally cannot fake a reflex. It is the perfect lie detector for catching non-organic hearing loss. If we really need to dig deeper, we move to brain and nerve mapping. We can map the actual electrical potentials traveling from the cochlea straight up into the brainstem. Electrocochleography, or ECOG, measures these electrical potentials within the very first 5 milliseconds of a sound playing. 5 milliseconds. Then we have the auditory brainstem response, or ABR. If you've ever seen a newborn baby with little headphones and stickers on their head for a hearing screening, that's the ABR. It's the gold standard, and we also use it to hunt down dangerous acoustic neuromas. And for profound deafness, we bring in ASSR to give us highly specific frequency data when other tests just max out.
Finally, let's look at Section 5, Specialized Assessments, Advanced and Pediatric Cases.
For highly complex adult cases, we bust out the advanced differential diagnostics. We're talking about the recruitment test, the short increment sensitivity index, and the tone decay test. The tone decay test is particularly fascinating. We play a continuous sound, and we see if that sound seems to just fade away into nothingness for the patient over time. If it does, that points a bright red flashing arrow toward a deeper nerve tumor. These specific tools allow us to draw a hard line in the sand, distinguishing between an inner ear cochlear issue, like Meniere's disease, and a retrocochlear lesion farther up the nerve.
Now, when our patients are children, we obviously have to adapt. You can't just tell a 2-year-old to press a button when they hear a tiny beep. So we swap out those standard diagnostics for techniques like visual reinforcement audiometry and play audiometry. We cleverly disguise a rigorous clinical assessment as a highly engaging, age-appropriate game. We teach them to drop a little block into a bucket, or we have them look over at a light-up mechanical toy every single time they hear a specific sound.
But the crucial point we're going to end on today, and frankly, this might be the most mind-blowing objective test we possess, is autoacoustic emissions, or OAEs. Get this test doesn't measure what your ear can hear. It actually measures microscopic, low-intensity sounds that your healthy ear produces all by itself. I really want you to just pause and think about that for a second. Your ear is not just a passive microphone sitting on the side of your head. The healthy outer hair cells inside your cochlea are actively generating and emitting their own sounds. If an audiologist runs this test, and those sounds are completely absent, boom, it immediately proves there is cochlear damage. But if the sounds are present and totally normal, yet the person still can't hear, that means the hearing loss is likely caused by a deeper pathology in the 8th nerve.
The huge paradigm shift here is realizing that our ears are active, sound-producing instruments. The precision of modern audiology diagnostics is just staggering when you step back and look at it. Over the course of this explainer, we have escalated from a doctor simply rubbing their fingers together and whispering from 6 meters away, all the way to using a machine to measure the invisible electrical hum of a single microscopic cell inside the inner ear.
Which leaves us with a pretty incredible final thought to wrap up today's explainer. If your ears are actively broadcasting their own microscopic symphony at this very moment, a symphony so real that doctors can literally hook up a microphone and record it, what other unbelievable, invisible mysteries are happening inside your body right now, just waiting for the right detective to investigate?